Madam will tell you.
Good evening, everyone. Welcome you all to Vijaya Diagnostic Radiology webinar series. I am Dr. K.L. Srujana, Consultant Radiologist at VDC Vizag. As we are all aware that there is an increasing need for distinguishing the focal liver lesions appearing in a background of cirrhotic liver. Today's webinar is a small attempt to guide us regarding the same. The topic for today is imaging of focal liver lesions in an cirrhotic liver. Our subject speaker is my colleague, Dr. K. Manoj, who is a consultant radiologist at VDC Vizag. He has done his MBBS from Andhra Medical College, Vizag, and has done his PG in radiology from the prestigious PGI Chandigarh. Welcome, Manoj.
Thank you, ma'am.
Now, coming to our guest speaker, he is Dr. Chalapathy Rao, who is presently the Clinical Director and Senior Consultant Gastroenterologist at KIMS Icon Hospital, Visakhapatnam. He is also a Governing Council member for the Society of Gastrointestinal Endoscopy, India. Thank you, sir, for coming to our webinar session.
Thank you, Dr. Thank you.
There is a lot about you. I'm just briefing about you. He received Sajja Chandramouli Gold Medal Award in Clinical Neurology for the year 2003 during MBBS at Andhra Medical College. He is the faculty trainer of spiral enteroscopy and endoscopic ultrasound, ERCP, and cholangioscopic procedures. He is also the first to initiate the services like endoscopic ultrasound and spiral enteroscopy in the region of Andhra Pradesh and southern Odisha. He has many oral and poster presentations nationally and internationally and a long list of publications in his name. He co-authored various chapters and delivered many lectures. Sir, there is a long list, so I'm not
let us go. Let us please go ahead into the main part. Thank you. Thank you. Yeah.
Sir, we need like a small like introduction from your side. Like we are seeing a lot of cirrhotic cases nowadays, and how do you usually work up these cases, and which cases do you send for imaging?
Right. So thank you, Dr. Srujana, and thank you, Dr. Manoj, for making me part of this program. And hello, everybody. So basically, as gastroenterologists and liver specialists, we come across these kind of cirrhotic patients very regularly. So not all patients predisposed to this malignancy, but they are at risk of malignancy transformation, because cirrhosis is actually a process of multiple degeneration, regeneration, multiple cycles of injury, and then there will be a lot of regeneration. So in that process, there can be nodule and fibrosis. So this is the basic definition of cirrhosis, right? So in this process, there will be a lot of molecular alterations, genetic alterations, which happen in liver, causing cirrhosis. So at that time, when this goes disarray, so there can be a risk of malignant transformation, especially hepatocellular carcinomas. So there are many other lesions also which we can see in liver cirrhosis. I'm sure Dr. Manoj will take care of those aspects in his lecture. But if we see a kind of cirrhosis, we are going to see what is the etiology first. So hepatitis B and hepatitis C have higher risk of cirrhosis induced hepatocellular carcinoma. So we'll be more careful, but in general, all cirrhosis, by and large, as per the guidelines and most practical approach would be actually go ahead with doing a screening ultrasound every 6 months along with alpha-fetoprotein. If you actually see something which is suspicious in either of these investigations, then go ahead with higher investigations, especially the cross-sectional imaging. CT is a very favorite choice for all of us. So it all depends where you are working, but majority of times CT is the preferred modality. A typical triple phase or quadruple phase CT, multi-detector, multi-dimensional CT is the choice. And if you have any still suspicion on it, you add an MR to that with the same protocol. If sometimes AFP is normal, then you may have to go for other markers like PIVCA or DEX carboxy prothrombin. So all these things are important, and you keep repeating these investigations every 6 months. Whenever there is a suspicion or you are seriously in doubt, then actually go ahead with some kind of invasive procedures. Sometimes we do a biopsy also, especially for radiological procedures. I'll come in the subsequent aspect of it. Yeah.
Okay. Over to you, Manoj.
Good afternoon, everyone. Thank you, sir, for your kind. Thank you, ma'am, for your kind introduction, and sir for your clinical inputs. The topic for today's discussion is focal lesions in the cirrhotic liver. So we'll start the discussion with cirrhosis and then delve into the carcinogenesis. And after that, we'll look at the individual focal lesions, and then we'll touch upon the lyrites. So cirrhosis is characterized by diffuse parenchymal injury with extensive fibrosis leading to architectural distortion and formation of abnormal nodules. So these nodules is due to repeated inflammation and fibrogenesis, which predispose the nodules to undergo dysplasia and malignant transformation. So what actually happens during the carcinogenesis? The most important thing is angioneogenesis, in which unpaired arteries progressively increase, which is coupled with reduction in the portal tracts. And there is evolution of the venous drainage from the hepatic veins to sinusoids to the portal veins. There is also formation of tumor capsule and fibrous septae. The fat as well as the iron content also increase within the nodules during carcinogenesis. Perhaps the most important change that occurs is the occurs in the expression of the OATP transporters, which reduce significantly as we progress towards the hepatocellular carcinoma. Okay, this is a illustration depicting progression of regenerative nodule to HCC. In a regenerative nodule, the portal triads are intact and there are no unpaired arteries. As we go to the low grade nodule, there are unpaired arteries as well as portal tracts, but the overall intranodular arterial flow here, as we see, is constant. With high grade dysplastic nodule, we see that there is more increase in the unpaired arteries with reduction in the portal tracts, and so on as we go along. So there are few more important things to see in this image. The first one is there is sudden drop in the OATP expression when we go from the low grade to high grade dysplastic nodule. Also, the baseline net intranodular arterial flow reduces in the high grade dysplastic nodule and the early HCC, and it drastically increases the moment we progress into the overt HCC. So what are the focal lesions? The focal lesions, most of them are related to cirrhosis and include the precursor nodules like the regenerative nodules, cirrhotic nodules, and dysplastic nodules. Additionally, there are early and progress types of HCC. The lesions unrelated to cirrhosis include hemangioma, focal nodular hyperplasia, arteriovenous shunts, hepatic fibrosis, cholangiocarcinoma, and metastasis. So coming to the first lesion, the regenerative nodules are formed as a normal response to the liver injury or altered circulation. So this is accompanied by fibrosis resulting in formation of nodules. These nodules, if they are greater than 3 mm in size, less than 3 mm in size, they are called as micronodules. If they are greater than 3 mm, they are called as macronodules. Also, giant nodules measuring up to 5 mm, 5 centimeters can be seen. On CT, these nodules appear isodense to the liver parenchyma, and there is no arterial phase hyperenhancement or any washout. On MRI, these lesions again appear isointense and sometimes hyperintense due to the lipid or protein or copper accumulation. They appear on T2 and T2 star images, they appear iso to hypointense. There is no diffusion restriction or arterial hypervascularity on MRI also. This is a axial scan, CT scan, in which we are not able to visualize individual regenerative nodules, but we can see the nodular outline caused by these nodules. So these are not well visualized on the CT images. However, on the axial T2 images, we can see multiple hypointense nodules distributed throughout the liver. These are partially visualized due to the presence of the intervening fibrous septae. Coming to cirrhotic nodule, it is a type of regenerative nodule which has increased iron content compared to the other regenerative nodules. It may be non-dysplastic or dysplastic nodule. On CT images, the NCCT appears high in attenuation and again does not show any arterial hypervascularity or washout. But on MR images, this time they are generally hypo or iso depending on the degree of iron accumulation. On T2 images, they are heterogeneously hypointense. The hypointensity on the T1 images is a pitfall, making because of susceptibility, we might mistake it for a washout on the venous or delayed phase. So this is an axial CT scan. The first image is an axial CT arterial phase image, which shows a hyperdense nodule in the segment 4. This we might suspect to be an arterial hypervascularity, but if we see the non-contrast image on the other side, we know that it is hyperdense from the beginning. So this is a cirrhotic nodule. Also on these MR scans, all these MR axial scans, the nodules are hypointense on T1 in-phase and out-phase images, as well as on the T2 images. But on the in-phase images, there is loss of signal intensity due to the intrinsic presence of iron. Coming to dysplastic nodules and early HCC. So low-grade dysplastic nodules do not show any atypia, do not show any architectural distortion or expansile subnodules, but they are different from the regenerative nodule because they have developed unpaired arteries and clone-like cell populations. These changes are more in the high-grade dysplastic nodule, but they are not enough as to classify as HCC. In early HCC, there is the most important finding is the presence of a stromal invasion, but there is no vascular invasion. So as far as the imaging features are concerned, the CT findings in dysplastic and early HCC are very similar. So they appear, they can be variable appearance on the NCCT images. On arterial phase, they are iso or hypoattenuating. However, some dysplastic nodules, generally the high-grade ones and the early HCC, can show arterial hypervascularity sometimes. On venous phase, again, these are iso or hypoattenuating. On MRI, again, the dysplastic nodules and early HCC are very, very similar. They can be hyperintense on T1 due to copper ion or intralesional fat, and they are iso to hypo on the T2 images. Then the early HCC can be more hyperintense on the T1 images due to presence of higher incidence of presence of the intralesional fat. Again, even on the MR images, both of them can show arterial phase hyperenhancement in some cases. But there is there are two important points to remember is that a dysplastic nodule, either low or high grade, is never hyperintense on T2 images and is never restricting on diffusion. Maybe unless and until there has been an infarction. Also, an early HCC can occasionally show T2 hyperintensity and diffusion restriction. So an important point to remember is that high-grade dysplastic nodules can transform into HCC within a span of few months. So therefore, it is less critical to differentiate the high-grade from the early HCC. But it is important that we differentiate the low-grade from the high-grade. The most sensitive method for doing that would be using hepatobiliary contrast agents. These agents, in addition to providing the vascular information like all the other extracellular agents, also give us hepatocellular function, the information regarding the hepatocellular function. So during hepatobiliary phase of while using this contrast, there is hypointensity, which is a predictor of pre-malignant or malignant lesion, because these nodules do not express OATP receptors, which help in the uptake of the hepatobiliary agents. So, a hypointensity is a strong predictor of pre-malignant or malignant lesion. This is a case from an article in which the lesion is almost iso-intense on the T2, T1, and the arterial phase of the T1 image. However, a subtle hypointensity could be seen on the venous phase of the MRI scan. So, hepatobiliary agents were given. It was given gadoxetic acid, and the lesion was persistently hypointense on the hepatobiliary phase, which suggests that this is either a high-grade nodule or a early hepatocellular carcinoma. Next, we come to a small nodule within a nodule. This is basically a small HCC within a larger dysplastic nodule. And it is important to note that a cirrhotic nodule that contains an area of iron sparing is very suspicious for HCC. Also, in an iron overload cirrhotic liver like in hemochromatosis, a lesion that is iron spared is also again very suspicious for HCC. On the CT scan, we see a relatively isodense lesion with small focus of hypodensity within. This small focus of hypodensity is showing arterial phase hypovascularity, and this focus is also washing out on the next subsequent phase. So, which suggests the possibility of HCC. Also, this MR was also done on this case, this patient, which shows a cirrhotic nodule, which was hyperintense on T2 with a small focus of intralesional T1 hypointensity. This focus was again hyper on T2, was showing arterial hypervascularity, and it was also restricting on diffusion weighted images. So this is a high grade dysplastic or a early HCC within a low grade dysplastic nodule. So coming to progressed HCCs, these are usually greater than 2 centimeters in size and have a blood supply from the unpaired hepatic arterial branches, and the drainage is via the portal venous. On pathology, they demonstrate microvascular invasion and tumor capsule. On NCCT, these are iso to hypodense and rarely hyperdense. On MRI, they are variable on T1 and generally hyperintense on T2. Diffusion restriction can also be seen. On the contrast images on both CT and MRI, they show non-rim arterial phase enhancement and non-peripheral washout on the subsequent phases. Also, because it has progressed and it has lost most of the OATP receptors, it will appear hypointense on the hepatobiliary phase with hepatobiliary agents. In this image, we can see heterogeneously hyperintense lesion in the segment 7 of liver, 6 or 7 of liver, and which appears hyperintense on which shows arterial phase hypervascularity. On the delayed phase, it shows a formation of an enhancing tumor capsule. On the hepatobiliary phase, the tumor is completely hypo compared to the adjacent liver parenchyma. The HCCs also show atypical presentation. Generally, sometimes they can be present with intralesional fat, or an HCC can also show intratumoral bleed, or they can present with an overt ruptured HCC. Ruptured HCC generally tend to lose their arterial hypervascularity when they rupture. This is not very well shown on these images, but they do tend to lose their arterial hypervascularity after rupture. Okay, this is the CT and MR imaging summary of the CT and MR findings in the precursor nodules in HCC. Okay, so it's a very busy slide. The important things to remember is, as we go along from the cirrhotic to progressed HCC, the T1 hyperintensity reduces and T2 hyperintensity increases. Also, there is higher chances of diffusion restriction and arterial phase hypervascularity as we progress towards HCC. Okay, the first lesion that is not related to cirrhosis is cholangiocarcinoma. Cirrhosis is itself is an independent risk factor for cholangio. The most common type of intrahepatic most common type of cholangio is intrahepatic type in cirrhosis. These lesions invariably need biopsy for diagnosis. How do they look in CT? On contrast images, they show either diffuse hypoenhancement or peripheral rim enhancement. And then they show gradual centripetal filling on the delayed phases. And they do not follow blood pool imaging like hemangioma. On the delayed phases, delayed enhancement is due to the fibrous stroma. Peripheral lesions can show capsular retraction, and because of desmoplastic reaction involving bile ducts, there can be dilated upstream biliary radicals. Again, on MR images, they are T1 heterogeneously hypointense. On T2, they are hyperintense with central hypointensity due to fibrosis. These show targetoid diffusion restriction. And on T1 arterial phase, we can see diffuse hypoenhancement or a peripheral rim enhancement, and with progressive central fill-in during the washout phase, during the delayed phase. This is an axial MRI scan of a cirrhotic liver showing a peripherally enhancing lesion in the arterial phase. And we can see that on the subsequent portal and venous phases, there is very subtle but gradual centripetal filling. So this case was diagnosed as cholangiocarcinoma. So coming to the confluent hepatic fibrosis, it can be seen in any type of cirrhosis, but most commonly it is seen with primary sclerosing cholangitis. The most common location is segment 8 and segment 4. On NCCT, it appears as a band or wedge-like area of reduced attenuation with adjacent capsular retraction. If it involves, it can also involve an entire lobe or a segment, causing marked volume loss. On the CECT images, these lesions appear isodense to the parenchyma on portal venous phase. But as with all other fibrotic lesions, they enhance on the delayed images. The crowding of blood vessels and bile duct can also be seen sometimes within the involved parenchyma. On MRI, they are hypointense on T1 images and hyperintense on T2 due to edema and compression of the remnant portal triads. There is no diffusion restriction, and on T1 images, they do not show arterial phase hyperenhancement. And there is delayed progressive increased enhancement on the portal venous and delayed phases. Trapped vessels are also seen better on MRI in at least 15% of the cases. This is an axial non-contrast CT showing capsular retraction in the segment 6 of liver. There is corresponding very subtle hyper density on the delayed phases, which is due to fibrosis. The same patient had undergone MRI, which showed T1 hyperintensity close to the area of capsular retraction, and it was corresponding. It was hyper on T2 signal weighted images. On the post-contrast images, we can see few trapped vessels appearing as a linear entities, and there is confluent enhancement on the delayed phase. Coming to metastasis of extrahepatic tumors are rare in liver cirrhosis than in the non-cirrhotic livers. What are the causes for it? There is fibrosis and distortion of small hepatic capillaries, which present a mechanical obstacle for establishing the tumors. The portal venous flow is also reduced, which limits tumor seeding, and further, the hepatofugal flow impedes the spread of metastasis. The other contributing factors include Kupffer cell activation, increased concentration of metalloproteinase inhibitors, and dysfunction of lecithins. Okay, now coming to the last part of the talk, which is lyrides. So, why do we use lyrides? So, all the lesions that we have discussed so far can be categorized into any one of these categories based on their imaging features. And each category has their own specific imaging guidelines, management guidelines, sorry. So, this helps to establish a uniform, standardized way of assessment and management approach for these lesions. So, what is the inclusion criteria? Though the lyrides are applied to people who are over 18 and are at high risk for HCC, which include those with cirrhosis, chronic hepatitis B infection, current or prior HCC. They also include patients who are liver transplant candidates and post transplant recipients also. But they are not applied for patients under 18 and those without any risk factors. Additionally, if the cirrhosis is due to hepatic fibrosis or any vascular disorders, the lyrides category is not applied. So, after applying the inclusion criteria, we go to the first step of applying the CT, MRI, lyrides diagnostic algorithm. There are actually 4 different algorithms. We are only discussing the diagnostic for CT and MRI. So, on the step 1, this is very extensive actually. The images that cannot be interpreted well due to degradation or omission of any important phase are categorized as LRNC. And these patients are advised to go or get a repeat examination or undergo another modality within 3 months. A definite tumor in vein is categorized as LRTIV. We'll discuss this further. Then there are benign lesions. A benign lesion can be classified as LR1 or LR2. Uh, can be classified as LR1 or LR2. If we are 100% sure that they are completely benign, we place them under LR1. But if we are anywhere less than 100% sure of it being benign, we just put them under LR2. Also, there is something called as a distinctive nodule without malignant imaging features. We'll discuss it in the next slide. If the lesion is probably or definitely malignant but not HCC specific, it is again classified into LRM. Okay, so the how do we categorize a nodule which has distinctive imaging features? First of all, what are the imaging features? They are T1 hyperintensity, T2 hypointensity, or a cirrhotic nodule, or hyperintensity on the hepatobiliary phase, or a combination of any of the above. The nodule, if it has any one of these and does not show any major feature of HCC or LRM category or any ancillary feature of malignancy, we look at the size of the lesion. If the lesion is less than 20 mm, we keep it under LR2. If it is greater than 20 mm in size, we keep it under LR3. Coming to lyrides TIV, if there is an unequivocally enhancing soft tissue lesion in the vein, we call it LRTIV. But then we look for a adjacent parenchymal mass. If there is a contiguous targetoid mass, it is categorized as non-HCC malignancy. If there is a contiguous LR5 mass, then it is categorized as LRTIV and definitely due to HCC. If there is no mass, we cannot visualize any mass, then it is classified as LRTIV probably due to HCC. Coming to LRM, the LRM is a category in which the lesion appears malignant, but it does not show major features of the HCC. So the first type include an infiltrated type of pathology characterized by a non-circumscribed or permeative growth pattern. These are also probably hepatocellular carcinoma only. Then there are few nodules that do not look like HCC, but then they suggest that they are of hepatocellular origin. And how is that? Because they show presence of fat, iron, or hemorrhage within the mass, or nodule within nodule architecture, or an intrinsic T1 hyperintensity. So these again are categorized as LRM. Again, they also may be HCC with atypical features, or they can be combined HCC and cholangiocarcinoma. A lesion showing marked diffusion restriction or necrosis is also categorized as LRM. The very common appearance, that is targeted appearance, if seen in any lesion, is characterized as LRM. So what is this targeted appearance? A peripheral contrast enhancement with peripheral washout and centripetal filling in the delayed phase is the targetoid appearance. Also, these lesions show targetoid diffusion restriction, which means there is peripheral diffusion restriction. Also, these are most likely they represent the intrahepatic cholangiocarcinomas or the combined HCC and cholangiocarcinomas. So once this is the last part of that step 1. So if the lesion does not fall into LR1, 2, TIV, LRM, LRNC, then we go through the major characteristics of HCC, that is the arterial phase enhancement, observation size, enhancing capsule, non-peripheral washout, threshold growth, and we categorize them into one of the 3 categories that are LR3, 4, or 5. We'll have a small discussion regarding the size and how they are placed into the categories in the next slides. So the major features are non-rim hyperenhancement, non-peripheral washout, enhancing capsule, size, and threshold growth. Non-rim enhancement and washout are self-explanatory. We need to look for an enhancing capsule in the portal delayed phase, which is a very smooth and thick, well-defined capsule around the lesion. And as far as size is concerned, we measure size in the portal or delayed phases because in the arterial phase there may be some corona enhancement, and we also do not measure it in the diffusion weighted images because there might be distortion. So how do we measure it? We take the largest measurement from the outer edge to the outer edge. Then a lesion qualifies as having threshold growth if it grows by at least 50% increase in size within 6 months. Okay. So when we are categorizing any lesion into LR5, we are almost 100% sure that it is HCC, and the clinician directly goes for the management instead of biopsy. The biopsy part is skipped when we put a lesion in LR5. So for diagnosing it as any lesion as LR5, the specificity has to be very high, 100% almost. So only few imaging characteristics and their combinations give us 100% specificity. So what are those? So a non-rim arterial hypervascularity with size greater than 20 mm, a lesion showing arterial hypervascularity non-rim and size greater than 20 mm. It shows any of the additional features which are non-peripheral washout, threshold growth, or enhancing capsule can be placed under LR5. But if the lesion is smaller in size, slightly smaller in size, that is 10 to 19 mm, and only one additional feature is seen, then we should actually look at the criteria of which criteria it is fulfilling. If it is fulfilling non-peripheral washout or threshold growth, it is again categorized into LR5. But if it is showing only enhancing capsule, the lesion is placed under LR4 category. Why? Because the specificity of the combination of these, the non-rim arterial hyperenhancement, the size that is 10 to 19, and enhancing capsule is not meeting 100%. So it goes into LR4. Benignity, some are favoring malignancy, which are general malignancy, and some are favoring the HCC in specific. We apply all these to the lesion we have, and depending whether they indicate benign or malignant characteristics, we'll either downgrade or upgrade the lesion. But an important point to note here is that an LR4 lesion cannot be upgraded to LR5 in spite of having any number of ancillary features of malignancy. Why? Because the combination doesn't give us a specificity of 100%. Okay. Coming to step 3, we apply tie-breaking rules if needed. Uh, if we are unsure whether there is a tumor in vein, we do not categorize it as LR TIV. And if we are unsure about between two categories to choose which one, then we go for category with lower certainty, either lower certainty of benignity or lower certainty of malignancy, which means we generally go towards the lean towards the LR3. And if we have a malignant looking lesion and we are doubtful regarding placing it in 4, 5 or LRM, then we go towards the lower certainty of hepatocellular origin. That means we favor LRM. In the final step of LIRADS, we ask ourselves if the assigned category is reasonable and appropriate. If we yes, we move on to the next observation, or if no, then we have to go back and reevaluate. So this concludes the diagnostic CT MR algorithm for LIRADS. Thank you.
Nice presentation, Manoj.
Thank you.
Sir, are you online? Sir, sir? Sir must be having some connection problem.
So thank you, Dr. Manoj. Excellent presentation. Am I audible?
Thank you, sir. Yes, sir. Yes.
Yeah, very nice. Yeah, so your presentation is in very great detail, and you have covered all the diagnostic aspects of HCC. So I think Dr. Srujana is taking some time to join because of connectivity issues. So I have few clarifications if we can initiate the discussion.
Yes, sir. Sure.
Hello?
Yes, sir.
Yes, sir. Yes, sir.
Hello? Yeah, can we initiate
We
discussion
can
before Dr. Srujana joins?
Sir, I'm already
I
in
think she's
the.
taking time. Hello?
No, sir.
Sir,
Hello?
sir, she is there, sir. Hello, sir.
Okay. I'm not able to, yeah, I'm not able to see her.
Sir, can you hear me?
Hello?
Hello? Sir, I'm there,
Hello?
sir. Hello?
Hello?
Sir, can you hear us?
Hello?
Hello?
Dr. Manoj, am I audible?
Yes, sir. You are audible, sir.
Yeah. Can we initiate discussion?
Yes, sir.
Yeah, Dr. Srujana is taking some time to join.
No, sir. She is there, sir. She can hear you.
Okay, right.
Yes,
So,
sir.
right. So I have few queries. Excellent presentation.
Yes, sir. Thank you, sir.
Yeah. So, how frequently do we use this hepatobiliary specific contrast agents in regular clinical practice?
In regular hepatobiliary agents are generally very less. Only multi-hands is there available for us. The for HCC, whenever we image a cirrhotic patient, we use a normal extracellular contrast agent, but only for differentiating low grade to low grade or high grade dysplastic nodule, we use hepatobiliary contrast. Or they are also used for differentiating any lesion that is inherently originating from the liver cells. Like we use it for differentiating FNH from hepatocellular adenoma, HCA. So that is it. It has limited value in day-to-day studies. But if we have specific query regarding which lesion is it, then we use it for problem solving. Sir.
Yes.
Ma'am, was I audible?
Yes, Manoj. You're audible only.
Oh, yeah.
Uh,
Sir is
sir,
not there.
sir is there actually. Sir, can you hear us? Manoj,
Yes, ma'am.
shall we close the session?
Yeah.
Sir, hello?
Madam, can you stop now?
Uh, I think sir is having connection issues.
Next what, madam?
Once, can you
Can
contact him or else?
Hello?
Hello?
Yeah,
Yes,
I'm
sir.
having connection issues. Yeah, I'm having connection issues. Yeah. So I heard your answer. So about hepatobiliary agents. Yeah. So the second
Sir, how will you
aspect.
be like?
Yes. What is your question?
Sir, how will you be following up the lesions which are having diagnostic dilemma radiologically? Like only with tumor markers and increase in their sizes, or do you do anything specific?
Yeah. So regarding the treatment, it all depends on the phase and stage of the tumor, the underlying liver condition.
Manoj,
Yes, ma'am.
shall we close the session or else? That's better,
Yes,
I
ma'am.
think.
Yeah.
It's,
Yeah.
yes. Okay.
Okay, ma'am. Thank you, ma'am.
Okay. Bye.